Hey, let me show you an approach I take for a lot of cases of patients who are, say, over the age of 55, 60, and have some chipping and wear on their teeth. Now, this patient came in with only one concern. She wanted her lower teeth straight. She never had treatment. Nobody has to make any explanations as to why they may want to do something about it, after so many years. That's probably one of the silliest things that a dentist can say, like, why do you want to do that? You've had your teeth like this for so long. Patient decides they want to have straight teeth. Now, what we do in a case like this is the teeth are all bunched together. And what I want to do is I want to broaden this arc. And you see what I'm doing is I'm laterally broadening and I'm broadening forward. That will get the space I need to make these teeth fit. Now, when the patient is biting down currently, the top teeth happen to be directly on top of those lower teeth, hitting almost on the edge. That means if I do what I just showed you to the lower teeth, I must do it to the upper teeth. So the upper teeth have to sort of move out of the way and match what's happening on the lower, so that when you are finished, you have the proper bite. So if you look in this view, you have a smile now that has broadened laterally and forward. This is really nice as you get older. It gives the patient, I wouldn't say it changes the thickness of their lips, but it does increase to whatever measurable extent possible lip support. And that's the direction you want to go as you get older. So it will give a fuller, nicer smile. The orthodontist is kind of like the structural engineer in terms of shaping things. However, like buildings, sometimes after the structure is set up and the structural engineer is finished, you need work on the facade. And what I haven't shown you yet is that when I broaden this upper arch to match the lower, I end up with space that was not there before. Here's the space. 1 full millimeter here, 0.5 here. Now I set this up proportionally to what I think would be best for the patient's tooth shape and size and their bite. The reason why this is the case is these upper teeth happen to be on the narrow side, especially her first premolars. Look at this tooth compared to this tooth. And so there's a collective narrowness to the teeth. The upper central incisors are about normal width. They were about 9 millimeters. There's a table you can find here. But the laterals were only about 7, and most are about 7.5. I'd say that's the average one. So basically, now if you go ahead and you do this treatment, you might, you can't surprise the patient and say, hey, you've got space now. That has to be the case. I've already done some interproximal reduction on the lower to even reduce the spaces that were inevitable. Now, maybe 20 years ago, I might have taken out a lower tooth, constricted the lower arch as I aligned, and then I wouldn't have to do that to the upper teeth. That is an approach you can take, but I really do not like taking out lower incisors because usually end up with overjet and you don't have great root parallelism. And I don't like moving teeth inward. I like to move them outward. And so I approached this patient after I worked up the case, and I explained this to her that after the treatment, she may have to get some bonding or veneers on these teeth, and that I totally could understand why she may want to not go down that route. And there are many adults who want to have the straight teeth, but really want to preserve their enamel. They don't want to do a big job. And they may at this point say, you know what, I didn't realize it was so complicated. I'm not going to do the case. And that's fine with me because you don't want to have an unhappy patient. But in this particular case, the patient was so excited and said, I understand what you're talking about. And I did notice I'm getting some chipping of these teeth. And so when the patient is done, she will get some work done on these teeth. And, sometimes patients that are older still have a belief that crowns are going to be opaque, monochromatic, and involve filing the tooth down to a large extent. They don't understand the advances in modern cosmetic dentistry. So something we have to educate them about. And so, by the way, when I first met this patient, I did have some concept that this might be an issue. And I explained that there may have to be some bonding or veneers. They went back to the dentist, and the dentist was like, what are you talking about? Veneers. They didn't understand my vision for what would be necessary after the teeth were broadened out. And so this is an option you could present to patients. Some may really want to go that route and some will not.